All right, so welcome. My name is Kelly Hendricks. I'm welcoming you all to a great evening tonight. We have great discussions planned to introduce the rhodium bioresorbable wick for rotator cuff healing augmentation. We have a small but mighty team at Atreon. Um, if you haven't met us yet, we're the loud ones usually at the society meetings, but it's all just because we're very passionate about our technology and what we have to offer for you surgeons and patients in the community. I want to thank the Biologics Association for hosting this webinar and for the ANA education team for all their work behind the scenes as well. For this evening, I'm excited to introduce Dr. Joseph Abboud with Rothman Orthopedics in Philadelphia, Pennsylvania. He is going to be our moderator for tonight's discussions. And then Molly Pett, our Director of Marketing and Commercialization, will introduce the product. And then I'm going to welcome Dr. Jed Johnson, founder and CTO of Nanofiber Solutions. It's a manufacturer of electrospun scaffolds and co-founder of Atreon. Dr. Johnson's going to do a deep dive into the science behind our breakthrough technology. And then welcome Dr. Vahid Entezari with Cleveland Clinic in Cleveland, Ohio, and Dr. Jonathan Levy with Levy Shoulder Center in Boca Raton, Florida. Both of those surgeons are going to present their case experiences and some discussion. So we'll end with a roundtable discussion, again, back to Dr. Abboud, and then we'll have plenty of time at the end for questions that you can enter into the chat box. So I want you to enjoy your evening tonight. And Dr. Abboud, please take it from here.
Great. If we could get the next slide up. All right, you can control. These are our disclosures. So, the reason we're having this discussion, this webinar, this explosion of technology that seems to have really flourished during COVID, is that it's still a very vexing point of our profession as far as patient outcomes with rotator cuff repairs. We know that rotator cuff repair is the most common procedure done around the shoulder. And despite our best efforts and really our advancements in technical know-how as far as how to pass sutures, how to do things arthroscopically, suture strength, etc., anchor strength, bone anchor interface, we still have a fairly big hurdle to jump as far as the failure rates that we still see in many patients, oftentimes older, but sometimes even younger. So, if you look at the variety of papers that are out there, there's no shortage of papers that have looked at, comparing results of various incorporation of technologies and how it's done and the re-tear rates and anywhere from, in the best hands, 5 to 10% for ideal patients to upwards of 90% in patients who have really massive tears that we would, in today's world, consider irreparable. And when Lisa Gallitz and Ken Yamaguchi were publishing on it, they were trying to repair these tears, but unbeknownst to them, they were failing. But patients were still doing okay, but not as good as if patients had the repair heal. The biologic environment is very challenging here. For a variety of reasons. There are a variety of methods that are developed, and I think that what I like to rely on now is the Rohi score to look at which cuffs are at risk as far as when you are trying to repair a rotator cuff. Which ones are you really worried about? I'm worried about all of them, but which ones are you more so worried about? And trying to guide them in the right direction. If you talk to patients, you know that they do their due diligence and they come in with I think a valid bias that rotator cuff surgery is extremely painful. It's a long recovery. And the last thing they want is after that entire process to go through an operation that's considered a failure as far as either their clinical judgment or visualization on MRI. So I think all of us are working strongly together to find a solution that will make healing more predictable and better. And tonight's focus is going to be on looking at that and various technologies that Rhodium and Atreon have to offer. There's no shortage of potential technologies out there, and I think that for the clinician, it's really sometimes very challenging to figure out. Okay, um, all the studies show something, not necessarily always positive or negative outcomes. Sometimes equivocal outcomes. Sometimes they're underpowered. Sometimes outcomes that are hard to really understand or believe. Variety of technologies from collagen patches to bovine collagen to electrospun collagen to um, anchors with scaffolds on them to using PRP or BMAC. A variety of technologies there, and they all come with a cost. And let's be honest, we're always worried about cost as more and more, um, you know, we look at the ASC and what we can use. Costs and methods of implantation are always a barrier for our utilization. So I think I'm just trying to set the table for the discussion. Jed is going to talk about the science, and really that's the key here, showing what science you have to help support what technology you're going to adopt in your practice. So I'll turn it over to, I think it's going to be Molly and then Jed to discuss this.
Thank you, Dr. Abboud. Sure, I have access here. There we go. So yes, before we dig into the science with Jed, I just want to give you a very brief overview of the Rhodium product and to share some of the goals that we aim to achieve with this unique platform and how we are differentiated among this market that Dr. Abboud spoke about, where there is a lot of different types of products out there. So we are really distinguished first and foremost by where we're implanted as an interpositional scaffold, commonly known as an inlay. And it's designed to address this inherently challenging biologic environment that Dr. Abboud, alluded to with a lot of this research is just looking at, and how we can kickstart that healing process and support the remodeling of the healthy tissue following a repair. So it is a fully synthetic, highly porous matrix that wicks and holds any active biology that's at the repair site. And that is going to promote cellular infiltration and proliferation at the tendon bone junction. And the scaffold is resorbed in 3 to 4 months completely. And Jed will get into more detail and expand upon these degradants of the polymers that are in the scaffold and how the resorption really facilitates a strong tendon to bone integration. So the key here is to enable healthy tissue remodeling. We want to improve these long-term functional outcomes and also provide this reproducibility and consistency of your repair that you may not find with other products. So as far as the technique goes, it's really quite straightforward, and the surgeon panel is going to dive into this a little bit deeper, but it is adaptable to your preferred implants and the rotator cuff repair technique that you currently use. It's anchor agnostic. There's no additional instrumentation or disposables that are required for this. It can be applied to repairs whether you're using 1 or 2 medial row anchors. And so basically the sutures are passed through the implant. Any kind of a standard instrumentation, oftentimes a grasper is used to push the implant down the cannula, position onto the bone, and then you continue on with your repair. So very efficient technique. It is available in a 2x2 centimeter size as well as a larger 3x4 size. So I just wanted to give a brief overview. Really delighted to hand it off to Dr. Jed Johnson, who are our CTO and inventor. So he will give you some insights into the science and the magic behind this technology.
All right, thank you, Molly, and thanks for the opportunity to present here some of our technology. Atreon is using our scaffold technology that one of the co-founding companies, Nanofiber Solutions, a company that I started years ago, is using for some other applications. And we started with these cell culture plates and looking at brain cancer cells specifically. And we've branched out into a couple of medical fields, Atreon obviously in the orthopedic field that we'll talk about, but also wound healing and vascular grafts. And in these instances, we can use these completely synthetic scaffolds and they remodel into healthy tissue. And that's really the goal what we're achieving here is not scar tissue. We're putting in a porous scaffold, and healthy tissue grows into it, remodels it, and we're producing, in the case of the blood vessels, a media, intima, adventitial layers. We can show, in the case of our wound healing examples, some healthy tissue coming back from that. So the goal is not mechanical augmentation here. The goal is healthy regeneration. And so with some of our data back in the day here, we had a horse that my dad worked on. My dad and brother are equine vets. And this horse ran into a hay rake, and hopefully the slide is going to pop up here soon. And my dad was going to put this horse down. My brother is a little younger and a little more aggressive, and decided to work on this horse. And so the second picture there is after applying our nanofiber scaffold to it. And you can see this wound is, approximately 3 by 3 feet. So it's a huge wound. And we had to quilt work in our nanofiber sheets. And then over the course of the next couple months, this wound closes really nicely. We see hair regrowth. We see healthy tissue coming back. That final picture there's sort of a crescent-shaped scar that's remaining. And horses really suffer from proud flesh and exuberant scar tissue. So traditionally, this type of wound would heal with big scar tissue protruding out from the flesh. And so to see hair, to see this healthy regeneration, sort of sets the stage of what we want to try to accomplish here in the orthopedic space. And so if we look at what a native architecture looks like within the rotator cuff, we see these traditional 4 zones, from going from tendon to the mineralized tendon tissue to the bony mineralized tissue, and then into bone. And so these 4 zones are sort of the traditional enthesis. And historically, people have tried to generate scaffolds, sort of what I call micromanaging those scaffolds, of where they'll put in mineral layers, they'll put in bone layers, they'll put in tendon layers, and try to recreate that hierarchy. And the reality, the body's too complex to try to recreate all those little areas. And so with Rhodium, we've created a scaffold that supports all 4 of those areas of regeneration. And so the scaffold can regenerate bone, the scaffold can regenerate healthy tendon tissue, and everything in between there. Similar story when we get to the healing cascade. And so whether we're looking at an interpositional repair of a rotator cuff, or we're looking at an onlay, or we're looking at tendon wrapping, or we're looking at skin, we have a scaffold that can support healthy regeneration and across the board in those different structural zones, but also in these different healing processes. So having a scaffold that can take you from the inflammatory stage to the proliferative stage into that final remodeling stage. And I think we've seen scaffolds that are really good in the inflammation, or maybe they're really good at proliferation, but they potentially suffer in that remodeling phase. And for us, that remodeling, that healthy tissue, is really the crux of the matter here, and what we're trying to focus on. And we have a lot of data, some of our publications on that healing and the M1, M2 macrophage modulation and controlling that proliferation. And if they would give me more than 10 minutes, I'd be happy to dive into that and showcase some more of that technology of sort of the underlying mechanisms. But when we designed Rhodium, we really had 2 things in mind. We wanted to focus on the biological and the mechanical aspects. And from a mechanical perspective, we have the 2 polymer system. It's PGA and PLCL. The PGA component breaks down very quickly, and the PLCL component sticks around for 3 to 4 months. And the biological component, and we'll get into this here in a little more detail, breaks down into very pro-healing compounds. And as you can see from the video there, we're readily absorbing any biological milieu that may be there. So you can apply PRP, you can apply BMAC, you can apply whole blood, and the scaffold wicks it in there. And you can see the scope shot there of our scaffold in position and absorbing some of that bone marrow coming up from the suture anchor holes. So if we focus in on the biomechanical side, This is a zoomed in image. The image on the left is what a native tendon looks like. This is decellularized tendon, and you see it's comprised of these fibrils, and the orientation of those fibers is what we're trying to mimic here with rhodium. So these are scanning electron microscope pictures, and we zoom in, and you can see our random orientation there, and we're modeling what God has already put into that body, into that structure. And so we're just reverse engineering that native tendon structure. And throughout the last 20 years that we've been working on fibers and cells, we've really tuned in this fiber size and the porosity of the scaffold to really hone in or amplify this biological effect. And so the image on the right just shows the importance of fiber size. We see a lot of textile scaffolds or a lot of porous scaffolds out there, but size really does matter here, that you can see these cells are actively gripping onto those fibers and moving on them. And that mobility of these cells is really important. That's how we're getting the bad stuff out of the wounds and the good stuff back into the wounds is through that cell mobility. So when we compare the biological component now of the scaffolds, the PGA breaks down into glycolic acid, and the PLCL is breaking down into lactic acid and caproic acid. And there's a whole host of references out there, and this is really kind of a burgeoning field in the tissue engineering world, that lactic acid and lactate is actually an extremely beneficial process for wound healing across the board. So whether it's external wounds or even diseased chronic cuffs, I think we can all appreciate there's a chronicity to some of these cuff repairs that is not being addressed by simple mechanical augmentation. And so there has to be something to kickstart that healing, to kickstart that repair process. And then the lactic acid is an incredible contributor to that. So I would encourage, if you want some geek out on some technology, to look up some of those references down below. And when we compare rhodium to some of the other scaffolds out there, the main thing would be allografts and other collagen technologies. And we see, and we know this, all biological tissue suffers from a heterogeneity in the sourcing. And so there's heterogeneity in your raw material, there's going to be heterogeneity in your final product. And by using a synthetic polymer, we can have consistency in our product, we can have consistency in the mechanical properties and the degradation profile, and more importantly, in the healing profile. And this also, we're going to show this here in a little bit with some of the data, but that consistency is really key. So one of our main publications was with Colorado State, and this paper actually just won the Best Basic Science Award for 2022. And so we're pretty proud of that, and pretty proud of just the sort of focusing on science that we've been doing here. Me personally, being an engineer, it's almost death by science. We don't know how to market. We do now, thanks to Molly and Kelly and our help. But traditionally, we're engineers and we're over engineering everything. But this paper really showcased the mechanical robustness of the healing. And so using 40 sheep, we isolated half of those to a 6-week time period and the other half to a 12-week time period. And what we saw after 12 weeks is that we had a 75% increase in breaking strength of that repaired shoulder compared to the control, which was just a traditional anchor and suture repair. And maybe more importantly than the 75% increase in breaking strength is also the reduction in the error bars of the data. And so as we see with the control animals, we had one super healer and we had a lot of non-healers. And you can probably appreciate that in your patient populations. And if we knew how to control that, we wouldn't have a 40% re-tear rate across the board for rotator cuff repair, but we don't. So if we can use something that can help ensure consistent outcomes for our patients, that can carry a lot of weight. And the way we're achieving these higher strengths, not at time zero, but out at 6 weeks, we're 33% stronger. Out at 12 weeks, we're 74% stronger. All goes down to these Sharpie-like fibers. And so if we look at that native enthesis, and hopefully the slides will catch up, we can see the tendon is really penetrating into the bone, and that's what is achieving our native strength. And when we repair these cuffs without a scaffold like rhodium, we don't have that native enthesis coming back. And that's the image on the right, and that's one of our controls. The image on the left is with rhodium, and you can see where the scaffold was. Now we have these purple collagen fibers that are penetrating into the bone. And these are blinded pathologist comments there underneath about the native direct insertion, and then on the control, no real attempt. So those are blinded pathologists. That's not our interpretation. And the next slide sort of zooms in on what that looks like here at a closer level. And so you can really see that interpenetration of the bone. And Dr. Romeo was actually there when we were pulling some of these animals apart, and our repairs actually tore like Velcro, and the control repairs the tendon would just pop off. And so you can clearly see there's a difference there in the healing, and then a difference in the failure mechanisms. But really what all that boils down to, it's great that we can help sheep out, but at the end of the day, we're here to help patients. And so to me, this slide really, is a life accomplishment work that we can show not just a decent improvement in outcomes, but here we can show a 50% re-tear rate in the control group. So this is just standard of care rotator cuff repair. And then in our arm with the rhodium scaffolds, we had a 7% re-tear rate. And so this is still early data. I think this is maybe 30, maybe 40 patients. Don't quote me on that. I apologize, but this is really encouraging for us. This is out to 18 months now. And so just a tremendous amount of data. And we have 2 clinical publications out now showcasing this data. So thank you, and happy to take questions at the end.
Thanks, Jay. That was great. I think we're going to transition to a couple clinical cases, starting off with Dr. Entezari from the Cleveland Clinic, I believe.
Thank you for the opportunity. My name is Vahid Entezari. I'm assistant professor of orthopedic surgery in Cleveland Clinic, and I'm thankful for the opportunity to share my experience with rotator cuff healing and augmentation, and how this augmentation grafting with rhodium fits into my practice. I have disclosures that are relevant to the topic of this talk, and I thought I will start with 2 of my patients that are representative of the patient population I think really can benefit from this. The first case is a 59-year-old right-hand dominant active guy that runs every day and had a fall during one of his runs on his outstretched arm 2 months ago. And as you can see, he has preserved overhead function, but overall globally very weak, and he has signs of rotator cuff weakness. When we look at this x-ray, he does have absolutely no arthritis, and is an MRI. He has most of his subscap is intact, but supra and infra is torn. And this is a large tear, and with all metrics, it's an active guy, and you want to get it back, and you're thinking about what to do with this tear surgically. So second case is a 50-year-old PE teacher, injured his arm 6 weeks ago playing sports. And as you can see on the exam, he has clear weakness of his internal rotation, but he has preserved overhead function. And on his imaging, again, minimal, maybe early stage of arthritis, but what he has is like a full thickness subscap tear that involves more than 50% of the subscap, and the rest of his rotator cuff is intact. Wanted to start with those and go back to those cases at the end. When we look at the rotator cuff around literature around the rotator cuff repair, these are the facts that we share. When we look at the success rate of the surgery by PROMs, it's very high. 80 to 90% of patients actually report their surgery as a success. But when we look at the imaging and mostly focusing on the healing, we realize that there are people who have high capacity for healing, and there are patients that don't have a high capacity for healing. So the patients that are ideal patient for healing are the ones that have small tear, low fatty infiltration, low refraction, acute tears, young patients that are healthy and non-smoker. And on the right, you can see the patients that have medium to large tears, high fatty infiltration, high retraction, chronic tear, older patients, maybe older than 65, non-healthy with diabetes, osteoporosis, and smokers are probably bad actors. And one thing that is very clear in rotator cuff literature is that absence of healing does not mean poor clinical outcome. And I put an asterisk in that, and I'm going to come back because as we more and more patient data coming out, we realize that the healed patients are stronger on exam and they have overall better function. So I'm going to bring these two boxes, and I'm going to ask you a question of when was the last time you treated a patient on the left box, or or when was the last time, or what percentage of your patients are fit in the right box that have 1, 2, or 3 of these variables. And so that brings up to the point that our patients are presenting with a variety of risk factors, and as a surgeon, it's very difficult to tease how we're going to identify patients that are good or bad actors. We went through this with Joe's presentation, but this is a meta-analysis of 32 studies and 2,000 arthroscopic rotator cuff repairs. And the goal was to look at double row repair or look at the suture bridge versus a single row. And obviously the study showed that those two are better than single row in a variety of tear size. But what I want to bring your attention to is that tears that are 1 to 3 centimeter or more than 3 centimeter have very high re-tear rate. And maybe this is bring up the point home that we were not doing as well as we think we are doing with the repair, even in the medium-sized tear when we repair them. Does healing matter? And there is some early literature which I argue that a lot of them are mixed patient population, and a lot of them speaks to the fact that maybe our patient-reported outcomes are not that sensitive. This is a recent paper that looks at 135 rotator cuff repairs in a younger patient population, and they followed them up to 4 years, and they excluded all the revisions, subscap tears, and patients who even had large and massive tears. So these are the patients that you expect them to heal and do better. And they defined the failure clinically as a constant score of less than 75. And they still had about 18% of these patients fit in that category. And the two predictors that predicted actually clinical failure, and as you can know, constant score actually has the strength as one of its measures, female sex and Sagai score of 3, 4, and 5, which means lack of healing in the rotator cuff directly predicted at 4 years patients' outcome. So I'm going to argue that if you use the right patient-reported outcome, you might capture actually that healing matters for the patient. So this brings me to this paper that tried, it's a rare incident that you can get MRI up to 1 year after surgery in 600 patients. And this is a Rohi score that was also mentioned earlier in the talk, is that they got MRI and CT arthrogram in all the patients, and they identify a list of predictors that actually leads to healing, and potentially you can predict who is going to heal and who is not going to heal. And these include age, AP tear size, tear retraction, fatty infiltration, bone mineral density, and essentially activity level of the patient. And when you look at the combined score for patients, if your Rohi score is 5 and above, you have 50% chance of re-tearing. And if your score is 10 and above, you almost have 85% chance of healing. So these papers and reading this literature kind of opens your eye to maybe re-tear rate is higher than what we think. We have a lot of patients that probably we can help them to get better healing and in return have better patient-reported outcome. And in my own journey, I started with thinking that this category, the patients that I should be augmenting or adding the rotator cuff are my older patients that have massive tear, have huge retraction, my unhealthy and diabetic patients in chronic tear and revision. And more, you read the literature, realize that cohort of patients will probably start with 70, 80% chance of re-tear in the rotator cuff. And probably that's not the cohort you want to focus for repair. And in return, patients who are younger, have medium to large tear, have moderate retraction. They have actually healing capacity. They're healthy. Their tear is acute or maybe at best acute or chronic, and they're doing in their primary surgery. That is the patient that I want to save with augmentation and improve their outcome and maybe bring their re-tear from 30-40% to 10-20%. And that's the cohort that I currently in my practice I focus. So if I want to go back to those two cases that I mentioned earlier, our patient had an upper subscap tear that I repaired with a single anchor. And as you can see, his rotator cuff is very mobile. This is an acute tear and with some delamination. And in my repairs, I always make sure that I can bring all the layers, including delaminated layers, back to the footprint. Here we're putting our medial row anchors and we're essentially opening up the bone marrow to the footprint. And I use rhodium grafts, and these videos are not faster. Essentially, they're not speeded, so you can see how long it takes for a large tear like this to pass a graft. So I essentially prepare the graft, create two holes with the handle left from my anchors, and I take my lateral cannula out because I don't want to have any resistance for introduction of the graft into the shoulder. And essentially it takes one try to get the graft into the shoulder. And you try to be gentle, but if the graft has not come in contact with water, it's actually very sturdy and it's very difficult to tear it before getting into the shoulder. Here we're laying the graft over the footprint. And as you can see, the sutures in the medial row are going through the graft, and the second graft is passed in the same fashion. And they lay over the footprint, and we continue to pass our sutures, making sure that we're passing the suture both through the delaminated layer and rest of the rotator cuff, and bring these sutures laterally to a lateral row. The key, here is to make sure that we are doing this based on the mobility of the rotator cuff. And when you see the final product, the graft is completely trapped and completely comes under the rotator cuff, and the rotator cuff gets compressed by your anchor and the sutures. And here we're accomplishing a double row repair, and is going to complete the repair with placement of lateral row. Here are the grafts is essentially sandwiched between the tendon and the footprint, and this patient continues to heal. And so the second case I wanted to bring up is an open rotator cuff subscap repair. And addition of this graft to any open repair is, to me, is almost very simple. You technique-wise, you go through the same preparation of the footprint, and then here I'm showing passage of the placement of the medial row anchors and passage of the sutures through the graft is very simple. The weakening ability of these grafts is amazing. You can see with two touch of the subscap tendon, the entire graft is red and they're wicked with the patient's blood. And we move on to pass the sutures through the subscap and bring them to lateral row and do a double row open subscap repair, and I incorporate the biceps. So I will finish with why I ended up adding this to my practice. I think it makes sense to add the augmentation where the healing happens. I know there are other philosophies, but I feel with the sound biology and basic science behind this, we're essentially putting the augmentation right at the healing interface. It does not cause inflammatory reaction because it's an inert synthetic material. The early results are intriguing, and you can add it, as I show, to an arthroscopic or open repair. They resorb in 3 to 4 months, and also from an expense standpoint, they're 2 to 3 times less expensive than current grafts. So I'm able to add those to my repairs without a lot of added costs. Thank you.
That was a great overview for your thought process and also your technique. Really enjoyed it. We'll discuss more of that during the discussion portion. Next, we're going to transition to Dr. Levy from South Florida. John?
Yeah, sure. Thanks again for the invite. This is actually on high speed. And really, purposely, there's a 75-year-old female with a retracted cuff tear, fairly active as most of my South Florida Iridians are. And the intent of this is to show the speed of this technique. So I deliver a graft through a lateral portal. I have 2 spinal needles coming from the top, and I literally exchange those needles for self-punching all suture anchors. And one of the criteria for me to use a product of any kind for grafting is it's got to be straightforward and easy to use. This technique literally this case is actually the first case I ever did. So it was a 0 learning curve. An idea of just trying to punch through the graft, making a small little hole with a spinal needle, nothing fancy, and then advancing each of these 2 anchors through and immediately deploying what I really call a footprint expander. And I think the science, the basic science here is showing more or less the ability to reconstitute what tendon origin truly should look like. That's a big game changer. And if you can expand the footprint, I mean, I think of a cuff repair. Historically, I've always used 2 medial row anchors, I tie knots, and I basically had 2 spot welds of where bone marrow elements, if I use a vented anchor, can come up through and just marry right up to the tendon edge. Now I'm expanding that footprint. I know that the bone marrow elements are going to leak through my anchor. They're going to sponge into the rhodium, which is truly a scaffold. And all I need to do is get a secure medial row repair and flatten the tendon on top of the graft. That footprint expansion concept, I think, makes a tremendous amount of sense. And there are parts of me that think, gosh, maybe I should be doing this on most of my rotator cuff repairs, but we can debate and discuss who are the best patients for this. But really, you can make a solid argument if cuff tears don't always heal, why not add something that might expand the footprint and improve your real healing potential? We always, take a shaver on the bone or make little tiny trephines in the bone to try to promote the healing elements from but I think adding some kind of footprint expansion here is a game changer. So this is my standard medial row anchor, tie the knots medial, and then eventually drape them over to the lateral row. And this probably is going a little bit too fast. Hopefully it's projecting that speed as well. Sometimes on Zoom, we lose some of the speed of the repair, but this in full time is a 20-minute case, but the portion of putting the graft in is like 30 seconds. I mean, we've all done grafts. This is a lateral row biceps tenodesis. I'm just integrating the bicep tendon into the lateral row. And, it's not uncommon for me to throw 8 sutures into a lateral row anchor, but you can see the biceps coming up. The biceps doesn't need a footprint expander, in my opinion. I think that thing heals pretty well. But the rotator cuff does. That's just finishing off with the marrow from the top, subacromial decompression. And this is what you see. So you see a little bit of the rhodium sticking into the shoulder. That doesn't bother me at all, knowing that this will resorb over time. If I put the anchor right at the medial row and I have about 3 millimeters on either side of that graft, it's not uncommon for me to see it just a little bit sticking in. I know it's staying in the right place and ultimately looking for healing. So, I intended on that being really fast just to emphasize that point that this is all about speed. Those of us who like to do a lot of arthroscopy hate screwing around and messing around and having a suture explosion. This makes grafting easy. It's simple. And I think it's accomplishing the goal we want.
That's great, John. It's a very slick technique and very reproducible. So thanks for demonstrating that. While I wait for you guys to show me if there's any questions from the chat, just want to kind of go back and go back to Jed for a second and kind of what was the driving force, Jed, to have you make this an inlay rather than an onlay? What kind of brought you to that? I know that you started with the brain. You didn't start with orthopedics, even though we think we're the brainchild of medicine and surgery. But how did you start first with brain cancer, and then wound healing, and then vascular grafts, and some synthetic grafts? And kind of what was the progression of that? Was it just that you saw the technology making much more sense at the bone tendon interface? Can you comment on that, Jed?
Yeah, it's going back a few years to grad school, we were working with
glioblastoma and trying to mimic how that cancer spreads and metastasizes. And so we were creating different types of nanofiber scaffolds in a dish. And that was really the start of nanofiber solutions. And so we started making and selling these dishes with nanofibers in the bottom all across the world. And we still sell those to pharma companies and research labs. And then we got into blood vessels as most tissue engineers do. And as we were putting these, we were typically doing double carotid surgery. So we would put in a carotid artery on both sides of sheep. And these could be 10-centimeter long vascular grafts. And we'd go back in a month and 3 months, and our nanofiber grafts were completely gone. And what's there now is a new blood vessel. And so going back to that intima media adventitia of generating healthy tissue and not scar tissue. And we had an investor who's an orthopedic surgeon, and he said, what would happen if we put that in a rotator cuff? And I said, well, I don't know. Let's find out. And that was the start of Atreon Orthopedics. And so just that concept of promoting healing rather than scar tissue. And when we looked at rotator cuff repairs, or I should say failures, we believe most of them are happening there at that enthesis. And so if we have a scaffold that can truly support healing, and we believe the failures are occurring at the enthesis, then that's really where we need the remodeling to occur. So we're putting the sort of the power where the failure is.
How predictable is when you're creating these synthetically electrospinning this? How predictable is the three-dimensional sort of overlay of this to replicate native tendon architecture? Is it, when you do quality control, how predictable is this?
Yeah, you're right. We do quality control in everything we make. The electrospinning process, we're generating fibers that might be 1 micron in diameter, just to help keep the math easy here. And a human hair is approximately 50 microns in diameter. So 50 of our fibers side by side would be the width of a human hair. So in the thickness of a rhodium scaffold, which could be 600 microns thick, could be a little bit thicker depending on which generation or which product you're using. But we're talking millions and millions of fibers in there. And so the overall construct is extremely consistent because we're not relying on just a few strands like a suture, for example.
Got it. One thing that you mentioned that wasn't lost on me as someone who's becoming follically challenged is that horse really had good hair regrowth when you used it for wound healing. I'm just wondering if you're looking at applications there, and should I, look into investing into Rhodium's hair regrowth technology? I know Eric Nordstrom could use some as well. Not Vahid yet; he still has a full head of hair. So it's also interesting to see who's on. I think one of the NFL quarterbacks, Derek Carr, is on the attendees here. So tell me a little bit more. You got me intrigued as far as the benefits of lactic acid in the healing process and how Rhodium helps promote this. Can you talk to that a little bit more? Because I know you were pressed on time, but just tell us a little bit more about that.
Yeah, we really saw this with our wound care product, where it's a very similar scaffold, and we actually got FDA clearance for it a year before the Rhodium got FDA clearance. And we were primarily treating these chronic wounds that have been around for years, and they've gone through the other treatment modalities. Unfortunately, we were only given permission after they exhausted other standards of care. And so these wounds had gone through collagen scaffolds, they've gone through amnion scaffolds, they've gone through xenografts, anything out there they've gone through, and they're still not healing. They're not even responding. They're still in full chronicity. And we would put one of our, in this case, this is Phoenix Wound Matrix. We would put one Phoenix onto that wound, and immediately the erythema would go down, the wound would start responding, it would start behaving as an acute wound. So it wouldn't close overnight, but it transitioned to an acute wound overnight. And as we dove more into it, we're understanding more about the pH. These chronic wounds have an elevated pH. And so adding in lactic acid as a sort of a blunt force pH reducer. And then that's when the peer-reviewed literature started popping out, all these papers on lactate and lactic acid and how it's modulating that immune response, and it's pro-angiogenic, it's producing VEGF, it's increasing the partial concentration of oxygen in these wounds. So it's really a whole slew of things that a pretty simple molecule is doing.
Great, that's excellent overview.
We've got some questions from the field in the chat, if you don't mind, for the panel. Does anybody have experience adding PRP or BMAC to the graft itself? Okay, I mean, I can tell you we've
Pretty
seen,
simple, yeah.
heard of it in the field, we've seen it in the field, but yeah, not often. It's, perhaps it'll be helpful, but don't know if it's necessary at this point. The other question, one of the questions that was posed was, and I think all of you have had this conversation with Jed over time, is the fiber alignment, is talking about like tendons have a certain alignment to it, but ours is a non-woven fiber. And so Jed, perhaps you could maybe touch base on that.
Yeah, it's a great question, and I have published a lot of papers on fiber alignment and cell migration and the benefits of fiber alignment. But in this case, really in any in vivo case, the fiber orientation sort of drops by the wayside because the scaffold we put in undergoes so much remodeling that it doesn't dictate the final structure. The final structure is coming from the mechanical cues and the chemical cues inside of the body. And so it's that mechanical loading in the cuff is what's generating that alignment in the final repair, not any alignment in the scaffold. It's I give the analogy of a road repaving. Your body's going in there and grinding up that damaged road and putting down a new road. So it doesn't matter what type of fiber alignment that we put in there.
Thank you. And then I think it was addressed by, all of you were talking about a bit about your techniques and that sort of thing. There was a question posed about, is not having a delivery device an issue? I think that's perhaps already answered, but obviously some of the competitors out there do have delivery devices, and has it hampered you? Have you heard anything from yourselves or colleagues? That was a question. It doesn't seem to have hampered you, but I guess learning curve wise, I guess I'll ask everybody that question.
Yeah, I mean, the first patch I started using was Rotation Medical's original patch before it became the Regeneten. And I thought that was revolutionary in its slickness of being able to deliver a graft and staple from the top. And it took, it would typically take a half hour, 45 minutes of trying to figure out how to drop a graft and then make it in under 15. This amplifies the speed of graft placement. I mean, as long as, there were times where I had failures of the staples or failure of the variety of things that I had issues with when I did that patch. I can cut this patch down to the size I want. I can, deliver it in literally seconds. And it's a lot more substantial, like the quality of what you're actually working with when you drop it into the shoulder. It's a very different substance than what I was used to when I used the Regeneten patch. Even though this is not a structural patch, it withstands a little bit more force and manipulation when you're dropping it into the shoulder. So I think from a delivery system, it's as difficult as delivering a suture and tying a knot. That's how hard it is. It's just dropping it down.
One of the audience members asked about re-imaging with these with the graft in places that interfere. Not to my experience, anybody on the panel have imaging issues as far as interfering with the image post-op. If you get an MRI, I wouldn't see it being an issue.
I mean, Brian Badman, has imaged, upward of like 50, 60 of his patients in follow-up. And so actually anything, it shows that Sagaya scores are lower and you don't see re-tear. I just wanted to comment, briefly on what John said. Everyone kind of develops their own technique and works for their workflow. And like in a lot of grafts in the market, as soon as they get exposed to water, they're almost like useless because like they disintegrate, they can't manipulate them, you can't like touch them. I mean, this is, comes as a thickness that, if, like you play with it in the water for a long time, any graft will dissolve, but this comes with the initial sturdiness that allows you to work with it, introduce it. And if you, as are fast and facile with your technique, you can easily get it into the shoulder. I've like adapted a couple of things. Like I try to introduce it through a cannula, and as you know, cannula is mainly designed to avoid water coming out of the shoulder. So those entrances are actually very tight. So my technique has evolved to actually not use any cannula and actually shave my path so that I'm not having any resistance. And if you do that, it's as easy as John said, like dropping and suture into the shoulder, and it goes very smooth.
Vahid, you comment on this quite a bit, but at this point, do you use a graft in most of your patients? I know that you said some of the patients that are, high risk, older, diabetic, you feel like it's not going to do much. But for some of the, lower risk Rohe score patients, are you using it more and more?
Yeah. So as I said, I have evolved because initially I was not using it, and I've not been trained to use graft, but this is naturally from my anxiety of leaving the operating room, especially in these young patients that I care about their healing. And they, where I am in, in my health system, I have a lot of my sport colleagues that take care of small to medium tears, and they send me actually a lot of patients that I think I can repair the rotator cuff, and they're thinking that this patient needs to have a reverse or have to have a muscle transfer. I see the patient, he fell like, 3 months ago, 2 months ago, and has a totally repairable rotator cuff. And I think that cohort of patients that are repairable, but they're, beyond that one single tendon tear, I think is the huge, improvement potential, have a huge improvement potential, because we know what we do, that patient is going to have 40%, 30% chance of re-tear. And I think that has become my to-go. I tend to not for my single tendons, jump to graft. I always have it available. If I'm in the operating room, the graft, the tendon does not look of good quality, but it's even a small tear, I'll add it there. And also any open repair I do is now I use rhodium for.
John, you're a high volume arthroplasty surgeon. Are you at this point incorporating it in your subscap repairs for your anatomics and or even your reverses?
No, I mean, I haven't adopted that as of yet. I mean, I think there's some logic and science probably there that would make it sense. I mean, I do a lesser tuberosity osteotomy. Could you put it in between there to try to increase your healing potential? I mean, I think there's all different ways of evolving. I have not adapted it yet. I purely use this for rotator cuff repairs. Now, that same arthroplasty population, my average 70, 75-year-old in South Florida is super active, and if I look at them in the eye and say, you're 75 years old, your Rohe score is way too high, I shouldn't be repairing your rotator cuff. No way. These are patients that really want to get back on the pickleball court and play at a high level they can't do with a cuff tear. So those are the ones I think that I am using it probably the most on, are in the left side of Vahid's categories, where those patients, to me, they have higher rates of not healing, but yet the consequence to their life of having a functional change from a rotator cuff tear is pretty high. So I want to try to give them the best chance. That's where I use it the most.
But in your video, I think I saw do you use typically one graft or sometimes two, or what's your decision tree there?
So it's purely based on number of anchors. If I use 2 anchors, I use 1 graft, and if I move to 3 anchors, I use one per a couple, and then they share 1 anchor. The grafts share 1 anchor. So I have not commonly used 1 anchor repair and added graft, but that's a rare use for me. If I'm doing it in an older patient that the tissue quality is really bad, you can drop it with one anchor.
And you can cut them down, right? I mean, you showed in all your videos, and I do it in mine. You kind of cut the footprint to different size for every patient, the amount of exposed footprint that you want to expand your healing to. So that is nice that you can actually manipulate the graft outside the patient, figure out the sizing, so it fits just right.
Any anecdotal evidence of Vahid? I think you may have talked about this as far as pain post-op. Have you seen anything that has kind of piqued your interest yet, or not really?
You know, I'm very traditional in the way I rehab my rotator cuffs. I'm not, taking them out of sling too early, and I think that's like very well established in our literature that maybe the range of motion might be different at 3 months, but not at 1 year. What is different is rate of re-tear in patients that you accelerate their rehab. So I've stuck to my guns, and I'm rehabbing my patients the same way. Either I'm grafting or not. But anecdotally, patients come back and their range of motion is accelerating faster. I've noticed that. I have a little bit more, I would say, as a surgeon, more confidence in my subscaps. I used to rehab my subscaps, slow them down up to 6 weeks, and now I'm cutting them loose by 4 weeks. So the ones that I'm grafting, so it also plays into my confidence of saying I did a little bit more for this patient, so maybe they can kind of tolerate another less immobilization. So that's been probably, I don't have a data to show, but it's more of my psyche of thinking that this patient had a graft, so they should be able to tolerate.
You guys both showed double row techniques. Do you ever use these in single row techniques for kind of, lateral bone is pretty soft, and you feel like you're not going to get good purchase, or are you generally always using a double row?
I think it lays down better with a double row. I mean, I'd worry if I only did a single row here that I might have some of the graft try to split out or something like that. I think having it mattress down and really be contained. I've actually thought of tying a traditional medial and lateral row right before I tie the lateral, just shoving a little bit of graft in there, because I think you could have that same effect by just letting it sit into the area where the footprint is living. But I have not gone to just an isolated single row alone.
So shoving it in there at the end, I like that. We have a question from Venezuela. Any place for this in repair of hip abductors, gluteus medius, and minimus tears?
Well,
it's a cuff of the hip, cuff of the lower extremity. I
was going to say the three shoulders. I guess I'll hit that. Is that we have people that have used it for that application? Certainly, because some of their shoulder, their partners that are working on shoulder heard about it. It's approved at their facility, but it is off label. Just so people are aware, is that this is approved for rotator at this point. We'll be going for expanded indication. That'll be sometime next year. That is something that we are eyeing, but it is off label at this point. So one of the other questions that was asked, I think a little bit earlier, maybe Jed hit it a little bit, was we're talking about fiber size and alignment, but there's also a question on porosity itself, about the how much spacing is in between the fibers themselves. Jed, I don't know if you're still on.
Yeah, our scaffold is about 85% porous, so it's very light if you pick it up, but still has the mechanical integrity, and it's in the works. But maybe we'll do some weighing videos where we'll load PRP or BMAC onto it and show the weight gain. But very porous, and it's also designed to the PGA component to break down very quickly, which opens up additional porosity so that cells can truly infiltrate through the scaffold. A lot of people in the tissue engineering world think the porosity of electrospun scaffolds is too small to support cellular infiltration, and that's 100% not true. And that's also why we have that PGA component break down, which opens up a lot of additional porosity for cell infiltration.
Thank you, Jim.
All right. Well, I think our time has come to the top of the end of the hour here. Let's see. Is Matt gonna wrap us up here?
Yeah, I'd just like to say thanks for everybody, the panelists, surgeons, for your time tonight. This was an amazing, candid discussion. And I encourage anybody that wants to learn more to reach out to our team. If you don't know our numbers, sales@atronortho.com can reach us for sure. We'd love to talk to you further about it, what you've just heard, and hopefully bring it to your patients as well. Thanks, everyone, and have a fantastic evening.